So, good afternoon, everyone. I'm Dr. Ashish from Surgical Gastroenterology, and we'll be discussing today nutritional evaluation of a surgical patient, which is a very important topic, having significant implication over the patient's outcome post-operatively, but overlooked topic in surgical specialties, unfortunately. We'll be going through what is the burden of malnutrition, what does the surgery do with nutrition in our patients, why should we evaluate, whom are specifically the patients, where should we evaluate, when we should start evaluation, and how should we evaluate, and finally the conclusion we'll be discussing. So coming to the malnutrition, what is the burden? Almost 50% of patients admitted to the hospital are malnourished, especially in a cancer patient, cancer group of patients where almost 4 out of 5 patients are malnourished, and it becomes important and problem because 25 to 30% more patients will become malnourished during their hospitalization. How does this malnutrition occur in these patients? It is because of basically reduced intake or because of increased demand of nutrition following trauma, clinical illness, sepsis, severe burn, or any major surgery. What does the surgery do? Surgery actually is a major trauma to the patient, which leads to acute stress condition, leading to acute activation of metabolism through endocrine activation and cytokine releases. And that leads to salt and water retention to maintain the plasma volume. It increases cardiac output, oxygen consumption to meet the systemic delivery of nutrients and oxygen-rich blood. It mobilizes energy reserve to maintain the energy process, tissue repairs, and to synthesize proteins involved in immune responses. What all these actually lead to? It leads to hyperglycemia and whole body protein catabolism. This actually catabolism leads to wasting of lean body tissue, especially the muscle mass. In a adequately pre-optimized patients, this physiological reserve is very important to meet all these functional demands in acute stressful conditions. And patients with low reserve, including malnourished, failed patients or sarcopenic patients, they are actually vulnerable to worse outcome because with diminished capacity to respond to the added demand of surgical insult. Why should we evaluate? This malnutrition leads to significant morbidities in post-operative setting, specifically leading to wound infections, wound adhesions, poor healing, breakdown of surgical anastomosis, and poor immune response to infection leading to sepsis. Ultimately, it overall causes post-operative significant morbidity and mortality, increases ICU and hospital stay, and ultimately leads to the increased cost of the treatment. It also has several non-specific effects, like on nervous system, it causes apathy, drowsiness, inability to clear secretions, leading to respiratory infections. There's loss of lean body mass, which increases the work of breathing, and patients become ventilator dependent. It reduces cardiac contractility. It impairs renal function. There's emotional and behavioral response, decreased response, leading to apathy and reduced or decreased reduced recovery following the surgery. It ultimately leads to sepsis and multi-organ failure. In many of our cancer patients where adjunct treatment is required, like chemotherapy and radiotherapy, their response will be affected in malnourished patients. And these therapies itself can cause worsening of this malnutrition in that particular patient. So being a modifiable risk factor which can be corrected, there are several controlled trials and meta-analysis which have suggested that just by correcting these nutritions and optimizing nutrition of these patients, especially in moderate and severely malnourished patients, their morbidity can be reduced by approximately 20% and mortality by nearly 10%. Whom are the patients to be evaluated? Actually, all malnourished patients on evaluation or a patient who is having risk of malnutrition should be evaluated, and risk factors described are patient related, disease related, or treatment related. In patient related risk factors, elderly patients, patient with sepsis or with chronic diseases like diabetes, organ impairment, and so on, or any history of past major gastrointestinal surgery, where there's short bowel pancreatectomy, gastrectomy, or bariatric surgery, which reduces patient's intake or causes digestive problems. Disease-related factors, where there's symptoms like dysphagia, nausea, vomiting, pain, diarrhea, or dyspnea, which reduces intake of nutrients, as well as upper gastrointestinal cancers, esophagus, stomach, or pancreas. They also reduce the intake of nutrients. Locally advanced diseases, metabolic diseases. Similarly, treatment-related factors are radiotherapy or chemotherapy, as we have come to know that these affect nutrition, polymedications, or patients on steroid therapy. On the basis of these risk factors and malnutrition status, patients have been grouped from 1 to 4. Group 1 is patient who is not malnourished and not having any of the risk factors mentioned in table 1, and the proposed surgery is not at high risk of morbidity. Group 2 are patients who are not malnourished but having at least one risk factor, or the surgery is at the high risk of morbidity. Group 3 are patients who are malnourished and but surgery is not at high risk of morbidity. Group 4 are patients who are malnourished and surgery is also at high risk of morbidity. So apart from group 1, group 2, 3, and 4 require nutritional assessment and optimization from the beginning. When to start evaluation? As malnutrition itself worsens the prognosis, so it should be evaluated in a patient from the beginning, so that can be optimized and we have a better long-term prognosis in that patient. Other treatments, if adjuncts are to be given, like as we know that chemotherapy and radiotherapy have their effect on nutrition. So before the start of these therapies, it should be started optimization, and it should be started from the beginning so that we have good time to optimize these patients nutritionally at least 2 to 3 weeks. There is no consensus, but European dietitian, this nutritional recommendation is screening should be started as soon as the oral intake of these patients fall. How to evaluate? First of all, we have to screen these patients. A screening tool, like if patient is having recent weight loss of 10% in 6 months or 5%, more than 5% in a month, if he's experiencing near or complete starvation for 5 or more days, if the recovery duration is anticipated to be prolonged. Once we have a screened patient, there are tools to available. Ideally, a tool should be sensitive, accurate, reproducible, applicable to all patients, especially bedside, and should be cost effective. They should also be able to assess the risk of morbidity and mortality. And same time, they should predict which are the patients where the benefit of nutritional supplementation lies. As with any other patient's evaluation, the evaluation of nutrition starts from the history, physical examination, then to laboratory values and other methods of evaluation. In history is very important. We come to know the nutritional status of the patient just by history, and we come to know what are the reasons or responsible for his reduced nutritional status, so that that particular cause can be corrected in that patient. So the history of deglutination and enteral absorption should be taken, like what patient takes orally, what is the quantity, what are the qualities of these nutrients he takes. There's lack of any specific food subgroup, or is he using any supplement. There's their ability to chew and swallow, their satiety. If patient is having early satiety, is not able to take full adequate diet. If there's dyspepsia, vomiting leading to reduced intake, if his bowel habits, which can give you some idea about the digestive power of that patient. Symptoms related to vitamin or trace element deficiencies. What tools we have, like body weight, which is a very simple bedside test. We can get patient's body weight, but it relies on comparison, where we compare this body weight from the patient's previous personal data or ideal body weight. Studies have shown that more than 10% of the body weight in 6 months has a bad prognostic indicator, has been a bad prognostic indicator. There are many formulas to assess the ideal body weight. Most commonly used are Divine and Broca's index. Limitation of body weight are as I mentioned, these body weight relies on comparison. So you need to have a patient's previous personal data, which may not be available every time. And if we compare patient's body weight with ideal body weight is a range of normal values, but it depends on which area patient belongs to. It depends on diversity of control population. It may be different for American people, it may be different in Asian population. In India also, there are differences in region-wise differences in normal ideal body weight of the patients. Weight loss determined by history is limited by poor predictive power. Recent gain or loss in weight do not directly relate to the similar proportional change in the nutritional status of the patient. Next tool is body mass index, which is patient's weight in kilogram divided by a square of the height in meters. The aim of this body mass index is to overcome the limitation of body weight, where we need like comparison. Here in body mass index, we do not need comparison, and studies have shown that BMI of less than 18.5 kilogram per meter square leads to longer hospital stay, ICU stay, increases post-operative complications, higher readmission rates, and delays the resumption of oral intake, delays the recovery of the patient. Limitations do not take in account the recent change in the nutritional status. Patient actually may be having BMI of 20, but we don't know previously what was his BMI. He might have been like having BMI of 24, which has come to 21. But this is this point it is 20. So we think that patient is nutritionally well, but patient might have lost significant weight before coming to the center. It's poor sensitivity with the baseline assessment, particularly in overweight patients. Individuals with high normal range can undergo significant change in nutrition status prior to estimation of having abnormal status. And same time, comorbidities which can lead to underhydration, edema, or ascites may confound its evaluation. However, being a simple, useful tool, bedside it can be assessed, particularly in patients with low range, where the benefit of nutritional evaluation lies actually. So this is a very important bedside tool to evaluate the nutritional status of the patient. Next tool is anthropometry, where we assess the mid-arm circumference, which gives an idea about patient's muscle mass, triceps and subscapular skin fold thickness, which gives an index of body fat. The limitations are, these are observer dependent and depend on patients, which side patient's dominant hand, whether it is right or left. Poor accuracy and specificity. Studies have shown that almost 30% of healthy controls were considered malnourished, but actually they were healthy controls. Its value is limited in elderly because of variability of age-related changes. Limited reference database is there. Absence of correlation factors with age, hydration status, and physical activity. And it is not useful in acute illnesses. So with history and examination, evaluation of nutrition may not be sufficient because there are diseases like kwashiorkor where there is depletion of visceral protein mass without change in body weight. So here comes the value of transport proteins like albumin, pre-albumin, and transferrin, which measure the visceral protein mass of the patient. So albumin, which is manufactured in liver, having half-life of 18 to 21 days. Its serum concentration actually depends on synthesis, degradation, loss, as well as changes between intra and extravascular space. Albumin value of 3.5 gram per deciliter have been found to be associated with increased morbidity in post-operative setting. It is useful in global assessment of the nutrition, but its value is limited in acute changes because of a half-life of 18 to 21 days. In a patient being nutritionally depleted in days time, it may not be affected. And being a acute negative phase reactant, it naturally declines in acute illnesses and post-surgery. So comparison cannot be done, and day-to-day evolution in nutritional status cannot be assessed in post-operative setting. But being a very cheap and everywhere available marker, this is a very good and prognostic marker for nutritional assessment, especially in acute especially in elective setting in chronically ill patients. Next are albumin and pre-albumin and transferrin levels. Having a short half-life, they are sensitive to changes in nutritional status, and they have ability to specifically reflect the protein loss. Limitations are there is erratic response to stress and illness, and their excessive cost, and they are less reliable and inadequate in universal use. Similarly, there are other markers like insulin-like growth factor, serum cholesterol, urinary urea nitrogen, creatinine height index, and delayed proteinase sensitivity. These markers correlate well with the nutrition, but the limitations are similar to the pre-albumin, albumin, and transferrin, having a high cost of these assessments. Next is the functional capacity and muscle power assessment. Muscle power is assessed with patient's hand grip strength and respiratory muscle strength, evaluated with his inspiratory and expiratory powers. Authors have told, like, have assessed this and then found that it to be better than weight loss and arm muscle circumference evaluation. But these are limited because these are observer dependent, and they need patients who are cooperative. And this may be affected in ICU settings or a patient who is sick, where narcotic, analgesics, and sedatives are being given. So patient may not be may not be in full response to cooperate for evaluation of these tests. Next is subjective global assessment. This is a tool first devised by Baker in 1982. It evaluates history and physical examination. It's a very easy tool, and paramedical staff can also evaluate this. In history, we evaluate weight loss, dietary intake change, gastrointestinal symptoms, functional capacity, whether he is bedbound, he is doing his routine activities, or he can do his strenuous exercises. And there are disease-related factors where the primary disease is responsible for low intake, like gastric cancers or esophageal cancers. Then physical examination, where we assess loss of subcutaneous fat, muscle wasting, ankle edema, sacral edema, and ascites. On the basis of subjective global assessment, these factors, patient can be categorized into A, B, and C. A is well-nourished patient, B is moderately malnourished, C is severely malnourished. There are several studies which have shown that patients who are severely malnourished, class C patient, have high morbidities and mortalities in post-operative setting. Another tool which is available is malnutrition universal screening tool, MUST, which evaluates three criteria. First is BMI, given points 0 to 2, depending on whether it is more than 20, 18.5 to 20, or less than 18.5. Weight loss in 3 to 6 months time. If it is less than 5%, it is given 0 value. If it is 5 to 10%, 1, and if it is more than 10% weight loss in 3 to 6 months time, it is given value of 2. Then third criteria is acute disease effect. Like, actually it is the disease which has led to the depleted nutritional intake for more than 5 days. Patients with diseases leading to nausea, vomiting, or gastric outlet obstruction or dysphagia, if these diseases are patient will be given a score of 2. On the basis of these scores, patients have been categorized into low, medium, or high risk patients. If the score is 2 or more, patient will be labeled high risk, and these patients should be given nutritional therapy, especially in hospital settings. As we know that patients' actual body weight may not reflect his lean body mass, which is actually important in nutritional evaluation. And surgical morbidity and mortality actually depends on lean body mass. This is called the sarcopenic obesity, where patient's body weight is okay, but he is having very low lean body mass. So this can be evaluated with DEXA, which is dual energy X-ray absorptiometry, which assesses lean body mass, fat mass, and bone density. The limitation is it is expensive and it's limited availability all over. Sarcopenia can be assessed. This is actually the low skeletal muscle mass. This can be assessed with abdominal CT cross-sectional image at the level of lumbar area, where we can assess the psoas muscle bulk. And sarcopenia is defined if the psoas muscle area is less than 4.38 centimeters square. It has been associated with increased post-operative morbidity and hospital stay. But the limitation is CT cannot be advisable in all patients. It increases the cost of evaluation. It's associated with radiation exposure and its limited availability in peripheries. These two images in the CT scan, we can see a normal patient who is non-sarcopenic. This is a psoas muscle, which is bulky, and we can see the thin, very thin psoas muscle in a sarcopenic patient. So now, till now, we have come to know like these are the criteria, these are the evaluation tools of the patient. And now the criteria to assess, to initiate the perioperative nutritional support. So there are criteria like if there is past history of severe undernutrition or chronic disease, if there has been a involuntary weight loss of 10 to more than 10 to 15% in 6 months time, or more than 5% in 1 month, if there is expected blood loss during surgery more than 500 ml, if patients is 20% under his ideal body weight, or BMI is less than 18.5 kilogram per meter square. In a pediatric patient, if there is failure to thrive according to the growth and development chart, if the serum albumin level is 3 gram per deciliter, less than 3 gram per deciliter, or transferrin levels are less than 200 milligram per deciliter in absence of inflammatory process, or patient's hepatic dysfunction or renal dysfunction. If there's anticipated that patient will not be able to meet his calorie requirement within 7 to 10 days in perioperative setting, or if a disease is there which is having significant catabolic insult like burn, trauma, sepsis, or pancreatitis. These are the patients where we should start perioperative nutritional therapy. In conclusion, malnutrition definitely is associated with postoperative morbidity and poor recovery, so it should be assessed in all patients. That too should start very early in the evaluation phase, so that we have adequate time to support these patients and have a better outcome. An ideal tool should be sensitive, accurate, reproducible, relevant in health and illness, applicable to all patients at bedside, and should be cost effective. But unfortunately, we don't have any tool which meets all these criteria. What remains simple and effective strategy is subjective global assessment combined with the easily obtainable objective parameters like albumin, concentration, and BMI, which are simple, inexpensive, and reasonably accurate in all patients. And these are the criteria, actually, these are the criteria being used all over the world. And especially in our setting, we also use these criteria to assess patient nutrition, especially in elective setting in a chronic patient. Thank you.